Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on a very important topic, that is updated approach to PUO in adults. And for this important topic, we need someone who is expert. So I would like to invite today's speaker with great honor, none other than Dr. Urman Dhruv sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in Internal Medicine, Director Internal Medicine and Diabetes at SCG Hospital Ahmedabad. So to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thanks a lot. Uh, what we are going to do in next 30 minutes would be to talk about pyrexia of unknown origin. And I'm thankful to Dr. Madhav Desai for few of his valuable inputs. So, before we know about pyrexia of unknown origin, we need to know what is pyrexia. And for knowing what is pyrexia, we need to measure temperature. So, let's go back to history a little bit. Do we know how did we start measuring temperature of the body? Well, the first known person to have used a medical thermometer was an Italian physician in 1602, meaning thereby around 400 years back. And then came Thomas Clifford, who designed a conveniently portable 6-inch clinical thermometer, which we still use either digitally or through other ways. So, fever. Fever is an elevation of body temperature that exceeds the normal daily variation and occurs in conjunction with an increase in the hypothalamic set point. So, temperature of the body is controlled by hypothalamus. So, fever means outside the normal daily variation. Then, what is daily variation? Well, oral temperature 36.8 plus or minus zero point 0.4, which is lowest at 6 a.m. and practically highest at 6 p.m. So, if you measure fever at 6 a.m., the limit is little different, 98.9. And if you are measuring at 4 p.m., it's different, 99.9. Very few of us know about this, but this is important. So, a morning temperature of more than 98.9 or an evening temperature of more than 99.9 would define a fever, which would be a little bit different in when measured with a rectal thermometer and also a little bit different in a menstruating female. And we need to know all these variations before we are entitled to talk about pyrexia of unknown origin. We also need to know about different patterns of fever, which could be continuous, where the fluctuation in temperature during the day should be less than 2 degrees Fahrenheit and should not touch the baseline in 24 hours. Intermittent, the fluctuation could be more than 2 degrees Fahrenheit, but the temperature would at least touch the baseline once. Remittent, fluctuation would be more than 2 degrees Fahrenheit and not touching the baseline. And relapsing, which would be period of pyrexia of few days followed by period of apyrexia, like as we can see in this lower chart, where it could be quotidian every fourth day, tertian every third day, quotidian second day, tertian every third day, or quartan every fourth day. What are the causes of fever? Fever occurs because of pyrogen. What is pyrogen? Anything that causes fever is pyrogen. It could be a microbial product, microbial toxin, or the whole microorganism itself. Like gram-positive organism can work as superantigens, can release toxin, or a gram-negative organism which can work on its own. Let's look at few of the cases before we start about PUO. A 21-year-old male having fever with rigors of 4 days, vomiting, headache, anorexia. Well, what investigation you will do? Answer is simple, CBC, ESR, PS for MP. And most really will get the answer This is not pyrexia of unknown origin, it's a short fever. Female 21-year, having rigors for 4 days, headache, backache, dysuria, vomiting. Normal examination except mild tenderness in right renal angle. Again, a easy take, CBC, ESR, urine, and most surely will get the diagnosis. If not, we may go for USG. A 25-year-old female, low grade fever for 3 months, weight loss 5 kgs, normal appetite, pulse 104, systemic examination normal, fine tremors are there, exophthalmos is there, fullness in thyroid gland. Again, things look little easier because this looks like dogs and cats in the street. These are the cases that we see frequently. At least within 3 months, we'll get a diagnosis. Same way, 25-year-old male, low grade fever, evening rise. Immediately the things would strike in our mind. Has lost 5 kgs in 3 months, diarrhea, dry cough, and we'll go to investigate him for tuberculosis. A 55-year-old male brought in unconscious state from railway station. We have to think about differential diagnosis with the help of certain investigation. But in all these cases, we'll be able to find out the cause reasonably rapidly within a couple of days, if not within a couple of hours, because these are all fever of short duration and the causes are limited. Causes are those that we see day in and day out. Then what is pyrexia of unknown origin? Let's come to the topic. Classic pyrexia of unknown origin was defined by Petersdorf and Beeson in 1961, practically 64 years back, as fever more than 101 degree Fahrenheit for more than 3 weeks, out of which 1 week has to be in hospital, and investigations done during this period failed to reveal the cause of fever. Within last 64 years, things have changed. Pyrexia of unknown origin has been classified into 4 different groups. So, what do we need to diagnose PUO? 1. Dedication. We should be inclined to do it. An active mind. At 6 p.m. in the morning after a hectic OPD, you will never be able to diagnose pyrexia of unknown origin because your thought process would be blocked. You should be able to know the differential diagnosis, multiple diagnoses. These are not cats and dogs in the street, these are lions and tigers in the street. Most important, while trying to solve a case of pyrexia of unknown origin, you should be a clever history taker. His story, the patient's story, has to be taken very, very properly. You cannot diagnose pyrexia of unknown origin from a file. You require patient. And most importantly, you require to give enough time, which most of us do not have. And that's why we fail to diagnose pyrexia of unknown origin. Like, there was a patient having recurrent UTI with weight loss. We went on talking to her for a long time, could not get any answer. We opened the file, one, two, three, four, about 150 papers. One of the papers showed urine showing fecal material, feces plus. That was ignored by most of the people. But we gave a thought to it, and then we realized that that was a case of rectovesical fistula leading to recurrent UTI. So, smaller things in an active mind would help you to diagnose PUO. Most of the febrile illnesses in adults either resolve before a diagnosis or develop distinguished characteristics that lead to diagnosis. And so we are spared from the difficulty of diagnosing a PUO. However, 5 to 15% of patients remain undiagnosed even after extensive evaluation because there are more than 200 conditions that can cause fever of unknown origin. especially in pediatric age group, connective tissue disorder, infection, oncology, and there's a huge number of diseases. So, what's the newer definition? PUO 1991, divided into four different categories: classic, nosocomial, neutropenic, and HIV related. Classic PUO, more than 38.3 degrees Celsius for 3 weeks or more, having more than 3 OPD visits or 3 days indoor at least. More than 38 degrees Celsius, 3 days nosocomial infection, no fever on admission or in incubation, which means a patient who has been hospitalized and develops fever having at least 2 days of incubation of cultures. So that is a nosocomial pyrexia of unknown origin. Neutropenic, again 2 days of incubation of cultures and neutrophil count less than 500. And HIV related, in a patient suffering from HIV, temperature more than 38.3 degrees Celsius, 4 weeks of OPD management, or 3 days of indoor, having 2 days of incubation of cultures. If these things are not able to diagnose, only then you can call it pyrexia of unknown origin. However, with a newer availability of investigations, pyrexia of unknown origin in 2025 can afford to exclude indoor hospitalization from its definition. So let's look classic PUO. It could be because of infection, neoplasm, collagen disease, or miscellaneous. Infection could be anything. We'll see a case later on. From tuberculosis to endocarditis to abscess, prostatitis, and whatnot. Neoplastic, again malignancy anywhere in the body. Any collagen disease can present as classical PO, and miscellaneous could be drug fever, thyroiditis, inflammatory bowel disease, or any other such disease. Even pulmonary emboli can present as classical PO. So, this is classical PO. Nosocomial infection commonly can occur because of drugs, pulmonary embolism, septic thrombophlebitis. Even sinusitis has been missed by many for a prolonged period. And of course, C. difficile enterocolitis. Immune deficient or neutropenic could be because of any opportunistic bacterial infection, especially viral or fungal. And HIV can be taken over by cytomegalovirus, MEC, PCP, Kaposi sarcoma, or lymphoma. These are the relative causes in different population. As you can see, in children, it is different. More than 65-year-old, it's different, where suddenly inflammatory cause take over. In cases of children, it could be infections which may be prevalent. In tropical countries, infections and inflammatory may be equal, while neoplastic may take care. HIV positive, mostly infectious. So, one should keep this chart in mind. What are the risk factors for pyrexia of unknown origin? We should know these risk factors because if we know these risk factors, we are always alert or on toes whenever such risk factors are encountered in a patient having pyrexia. Exposure to radiation or occupational exposure, family history or medical history of prior malignancies, low socio-economical levels, travel to endemic place, exposure to animals, even presence of underlying infections such as HIV and inflammatory disease, and you should be cautious, alcohol, unvaccinated individual, especially elderly one, and recent contact with infected individuals. So, how do you go for diagnostic workup in a case of pyrexia of unknown origin? What's the protocol? Well, the protocol says that there is no protocol, no set rules, no algorithm, but still it has to be methodical. First of all, and most important, correlate all histories. Sit down with the patient, sit down with the relatives, try to identify the nature of fever, when did it start, look for occupational travel history, Look for previous illnesses, surgeries, psychiatric illnesses. Look for dietary habits, consumption of dairy products, alcohol. Look for animal contacts, very important. Sexual history, especially history of exposure, and drug history. Remember, about 20% of patients having PUO have some drug induced fever. And remember, all classes of drugs can cause fever, starting from antimicrobial to cardiovascular drugs, anti-neoplastic, and drugs acting on CNS. If you look at the list of drugs that can cause fever, all the pharmacological textbook would show you a long list. But to me, the commonest one in postoperative period or in a medical setup is none of these but a cephalosporin, which is a very common cause of drug induced fever. The other one is nifedipine, isoniazid, very important causes. So, drug fever usually begins 1 to 3 weeks after starting the treatment, and that's why you are stuck up. It could follow any febrile pattern. It's not always necessary to have eosinophilia or rash. About 20% of patients would have it, but 80% of patients having drug fever may not have eosinophilia or skin rash. How do you diagnose it? Omit drugs. Omit drugs that are going on in a patient of pyrexia of unknown origin, change to alternatives, and if the fever remits in 48 to 72 hours after stopping the offending drug, most likely it is going to be drug fever. What are the things that you look for in physical examination? Head, look for sinuses. Very important cause. Temporal arteries should not be, you should not miss to palpate temporal artery because temporal arteritis is another cause. If they are palpable, tender, just go for ESR and you'll clinch the diagnosis. Forgetting to examine the retina, fundus, and you may miss disseminated granulomatosis. Skin and nails can give you so many information, starting from bacterial endocarditis to aortic regurgitation to any pulmonary pathology. Obviously, thyroid palpation is important. Looking for murmur is important. Per rectal examination, something most of the doctors clinically managing patients forget to do or avoids doing or ignores doing. You may miss a per rectal fluctuance or a prostatic tenderness. Genital examination can miss epididymoorchitis and lower limb tenderness. If you miss, you can miss the DVT. So, a full examination of spine and joints, very important. Review of dentition, because teeth are the commonest places where infection can take place without informing you. Fundoscopy, pelvic and rectal examination, especially prostate in male. Tip to toe examination of skin for rashes, scars, ulcers, bites, pressure areas, abnormalities of hairs and nails. Temporal arteries, breast examination in females. Most important, any implant is a potential site of infection. Even after 6 months, 1 year, or a couple of years after it has been implanted. It could be a prosthetic joint, it could be a pacemaker wire, even a central or peripheral vascular line, shunts, grafts, and meshes. A hernia operated by hernioplasty, herniorrhaphy, can lead to fever later on. You'll go on searching everywhere, but forget to put a hand or palpate the hernial site. Particular attention should also be given to recent travels, exposure to pets, the work environment, and recent contact exhibiting similar symptoms. Skin, mucous membrane, lymphatic system, abdominal palpation, organomegaly. Certain red flags, very important. Weight loss. Immediately, you should have 6 or 7 diagnoses in line in your mind. Increased lethargy, drenching, night sweats, inability to perform activities of daily living, and changes in other symptomatology. If you are treating the patient of PUO on OPD basis, and if you suddenly find any of these red flags, it is time for you to admit that patient. The most common causes you should keep in mind. Of course, in PUO there is nothing common, but uncommonly common or commonly uncommon causes of PUO in an immunocompetent individual would be infective endocarditis, especially culture negative endocarditis. Keep in mind, discitis, osteomyelitis, occult abscesses, very, very common, a deep seated gluteal abscess, you will never be able to know, and an infected implanted device. Patients who have been hospitalized in last 6 months are at an increased risk of hematogenous spread, and in all cases, a positive microbiological diagnosis should be attempted before commencing antimicrobial therapy. If you are suspecting endocarditis and negative blood cultures are there, think about abnormal organisms. Fastidious and slow growing bacteria could be an factor. Extended cultures for HSEK organisms, which are actually fastidious hemophilus like organisms, or serology for Coxiella burnetii, Q fever, Bartonella, or Brucella should always be done. Resistant organisms are becoming increasingly common, especially if a patient has been hospitalized in last 6 months, or who has received repeated courses of antimicrobials, or who has traveled abroad. Think about resistant organisms, especially if he or she has diarrhea. Of course, in elderly patient, think about routine investigation like tuberculosis, HIV, and syphilis. A traveler who is returning to his own country after travel. Remember, 25% of patients reach to the OPD for fever. This is a place where you are supposed to ask the accommodation, sexual exposure, chemoprophylaxis and antimicrobials used, places that he has traveled to, length of time spent there, food, beverages, activity, use of bed nets, and bites. A person who has gone on trails could be bitten by the parasites or organism from the soil, animal and freshwater contacts. Less exotic causes should be thought of. So, what are the diagnostic approach? Investigation should proceed through at least two stages of baseline test. Never go for blanket test. A patient coming to you on 21 days, just don't order test because you are supposed to order. Always have some logic behind giving the test, because the more the tests that are done, more false leads would emerge and you will be misled. So each investigation that you are ordering should have some pre-test probability. So start with complete history and physical examination. If there are positive findings, order appropriate and specific diagnostic test. There are no positive findings, then order routine test, CBC, ESR, LFT, urine, blood and urine culture, skin test, X-ray, sonography. If there is something positive, again order appropriate test. But if something is not there, think about the second group of test. It could be CT with contrast or CT. What we generally do is divide the patient into 5 groups or 4 groups. More likely to be infection, then go for this test. Urine sputum culture, cultures for AFB, VDRL HIV, serology for CMV, EBV, ASO. More likely to be malignancy. Hematology, go for peripheral smear. Very, very important. We hardly think about peripheral smear. Contact a good pathologist and you'll get the diagnosis. Go for serum protein electrophoresis. About 5% of patients would clinch the diagnosis from serum protein electrophoresis. And then lymph node or bone marrow biopsy. If you are suspecting a non-hematological malignancy, Then you go for specialized investigation like mammography, contrast CT, endoscopy, upper or lower GI, bone scan, or gallium 67 scan. If you are thinking autoimmune, we know limited test, ANA profile, full ANA profile, RF factor, quantitative, qualitative, and temporal artery biopsy. But if you are thinking miscellaneous, meaning thereby your patient is neither falling into the infection group, probable malignancy group, probable autoimmune group, then you require a diagnostic workup like endocrine, AC levels, barium studies, venous Doppler, lung scan, or even WBCs, whole body scan. These are again the groups of investigation that you can do. I've already enumerated for infection, the starting from echocardiography, transesophageal echocardiography, line cultures to PET CT. For inflammatory, ANA, NCA, NTCCP to even LDH. Neoplastic could be echocardiography, colonoscopy, transesophageal echocardiography, or even biopsy. And when it comes to pituitary, think about endocrines like pituitary screen, thyroid function test, etc. As I told you, each test should be performed when there is a reasonable pretest probability of the condition being present. Increasing early use of PET CT these days and the development of new molecular and serological tests for infection have improved diagnostic capability, but up to 50% of patients still have no cause. Reassuringly, longer the time to diagnose, the cohort of undiagnosed patients have generally a good prognosis. So, last 5 7 minutes, and we'll go to a case seen by Dr. Aniket Shah, our expert in infectious disease, and myself. So, 18-year-old boy, thalassemia major, receiving PCV transfusion every 21 days on oral iron chelation therapy. No major past medical history, presented with the following chief complaints 45 days. I'm sorry about the wrong spelling of complaints: fever, right hypochondrial pain, back pain, and weight loss. And what did we do? We analyzed each symptom. He was all right before 1.5 months. Fever was high grade, up to 107 degree Fahrenheit, 2 to 3 spikes with chills and rigors. So immediately our mind would start thinking about patients developing or the organisms developing fever with rigors or the causes associated with mild headache and body ache, meaning thereby systemic symptoms are minimal, no night sweats, no diurnal variation. Of course, this does not rule out tuberculosis. He noticed pain in right hypochondrium, second symptom. Again, we analyzed it, stabbing in character, aggravated by coughing and deep breathing. Well, very important question. Don't forget to ask because it probably suggests a pulmonary pathology, a diaphragmatic pathology, or liver. Moderately severe in intensity, radiating to back. Could be liver, could be pancreas, could be any structure in between. No diurnal variation, no relation with meals, no alteration in bowel habits. Less likely from the stomach. The boy had back pain, third symptom, which was on either side of the spine in lower back. Continuous boring pain. Could be from spine, could be from pancreas, could be from retroperitoneal tissue. Increases on sneezing, coughing, and deep breathing, more likely spinal in origin. Associated with difficulty in walking with straight back, again points to the spinal involvement. Relieved by lying supine, very important, and non-radiating. Now ask ourselves, how many times do we ask everything that has been shown? Fever, all these questions. Right hypochondrial pain, all these questions. Back pain, all these questions. And each question is narrative, specific, suggests or rules out certain things. Physical examination, apart from gibbous present, tenderness along paraspinal region, rest of the things were reasonably okay. Of course, hepatosplenomegaly was there. So looks very likely if you think about cats and dogs. looks very likely to be tuberculosis. Let's see. Count normal, HB low, he is having thalassemia major, recurrent transfusions. CRP high, bound to be high after 21 days of high grade fever. ESR is high but not very high for a boy of 18. SGPT, SGOT is high, are high. Obviously, liver is palpable, tender, right hypochondrial tenderness, fever. So liver enzymes were bound to change. Sugar normal, renal function normal, liver function test INR 1.6, lipase alkaline phosphatase bilirubin normal, culture negative on couple of occasions, and urine routine micro normal. Sonography obviously will go for suggested hepatomegaly, multiple tiny hypoichuria, and central tiny echogenic spot. Very classical, either infiltration in the liver or abscess or metastasis. They are more than one, so more likely to be abscess with high swinging temperature, less likely to be metastatic in an 18-year-old boy. Moderate splenomegaly, we have to think about certain parasites or tuberculosis, but there is no ascites or lymphadenopathy. So, all in all, started with antibiotics, cephalosporin, and azithromycin. Somebody had already done it. Sonography was repeated after 7 days. Nothing happened. Same. Symptoms, same. No change in the symptoms. CT was done. Showed multiple necrotic nodular infiltrates, one of which had already ruptured on the anterior subcapsular collection. Multiple enlarged nodes at porta and upper abdomen. We worked up for back pain also, and dorsolumbar spine showed these characteristics. MRI suggested altered signal intensity of marrow involving D10 vertebral body with right paravertebral granulation tissue. So fits absolutely wonderfully well in tuberculosis. This is MRI spine. So what is the summary? 18-year-old male child, thalassemia major, 6 weeks of high-grade fever, in fact 3 weeks of high-grade fever with chills, rigors, multiple liver abscesses, paraspinal collection, multiple enlarged abdominal nodes with periodontitis. Obviously, AKT was started, thought about all these diagnoses, but AKT was started. No improvement whatsoever 15 days after starting 4-drug AKT. CT guided aspiration was done, sent for culture. What did we do? During this period, we started thinking about which infections are common at his age, which infections are common in his geographical location, which was from Rajasthan, which infections are common which can cause such picture, suppurative, chronic infections, and which infections are common in thalassemia major. Surprisingly, we got the answer from the fourth question. We realized that we asked the pathologist to go for the culture, and what was the answer? The pus grew B pseudomeli in two different labs, and it turned out to be a disseminated melioidosis. 7% possibility of B pseudomeli in thalassemia major patients. Ceftazidime was given, supportive care was taken, coughing was there, but ultimately the patient improved, fever disappeared, and after 14 days of ceftazidime injectable, he was fine and cotrimoxazole was continued. What was important in this case? Thinking about the out of the hat. So, concluding my presentation about pyrexia of unknown origin, when investigating a patient with pyrexia of unknown origin, consider possible etiologies in each of the following broad categories. Divide the patient into more possible infective, more possible inflammatory, more possible neoplastic, and more possible miscellaneous. Address each in turn. Pyrexia of unknown origin is a diagnostic challenge, and early involvement of specialists and a team is important. The balance of causes of PUO varies over time and across different populations. Investigation should be undertaken based on the most likely cause. Please, blanket investigations are not recommended as positive or equivocal tests are difficult to interpret. You know there are so many RA false positive. You know so many LE cell false positive. You know so many ANA false positive. So please do not go for blanket investigation. Give a proper medical logical argument for the each test that you order. The blanket test can be misleading and potentially cause patient harm, like in this case where we had started AKT. Empirical therapeutic trials, as was done in this case, are not recommended before a diagnosis is made unless the patient is believed to have miliary tuberculosis, central nervous system tuberculosis, temporal arteritis, where you can start steroids, infective endocarditis with severe sepsis. Otherwise, it is better to wait and watch. The overall outcome of patients with PUO is good, especially when no cause is found. So, final word, PUO remains a clinical challenge despite greater understanding of the diseases responsible and increased access to diagnostic tests. Thank you very much.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Sure.
First question I can see from Dr. Subramaniam. He is asking like, when do you recommend starting empirical treatment in PUO cases, and how do you balance that with antimicrobial stewardships?
So basically, I already answered because that was the most expected question. That whenever there is a septic shock following a PU of 3 weeks, it's a dire emergency. Whenever there is a culture negative infective endocarditis, which may ultimately end up in a cardiogenic shock, that is somewhere where you should go for it. Or in a suspected case of tuberculosis, where there is miliary tuberculosis, where there is Addisonian crisis, or where there is a central nervous system tuberculosis suspected, leading to some central nervous system symptoms or signs. These are 5 occasions where you can start with antituberculous drugs or antimicrobial agent empirically. Otherwise, most of the PUO patients are stable and you should not do. In fact, you should stop all possible antibiotics because all antibiotics are known to cause drug fever.
Thank you so much, sir, for sharing your expertise on that question, sir. I hope it will be very much impactful. We have another question from Dr. Anurag. He is asking, how has the role of advanced imaging like PET CT involved in the diagnostic workup of PEO?
Yes. So that's why I added 2 things. One is the newer definition of PUO does not insist on 3 days hospitalization as was done by in 1961 and 1995 definitions. The reason is most of our patients can afford to undergo PET CT thanks very much to the accessibility to PET CT in India, in general hospitals and in private hospitals, and the the ease with which can do it, and therefore the use of PET CT more common done by physicians has definitely led to lots of diagnoses which went without diagnosis for a long time. So yes, PET CT should be encouraged after 3 weeks of all possible investigations that has been done.
Thank you so much, sir, for taking out your important time and sharing your knowledge. I hope it will be very much helpful. One feedback from Dr. Subramaniam, very good presentation. I hope he has really enjoyed. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session for today?
Thank you, Faraz, and thanks, IJCP. Thank you very much.
Welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take care of yourself. It was great honor
Anytime.
to have you, sir. Thank you.